Thank you, Mr. Chairman. Secretary Sebelius, thank you for being here. Yesterday, Administrator Tavener testified on the security testing for healthcare.gov, which was broken down into testing for the hub and for the federally facilitated marketplace system. She testified that there had been no end-to-end testing on the federally facilitated marketplace. In fact, she approved a September 27th memo to move forward with issuing the authority to operate. The memo specifically noted this, and I'd like to quote it. Quote, from a security perspective, the aspects of the system that were not tested due to the ongoing development exposed a level of uncertainty that can be deemed as high risk for the federally facilitated marketplace system. Yes or no, were you aware of that memo?
I was made aware of it recently. I did not know that the memo existed in September.
How many times did you and Administrator Tavener talk about the security aspects and specifically this decision to move forward with the authority to operate?
We did not discuss the authority to operate.
Did you at any point notify the White House of the security concerns that existed about the exchange?
I would say that there were conversations, Senator, about risk in terms of a new system up and running, but I was not aware of this, and I did not have these discussions with the White House because I wasn't aware of them.
Did the White House know that there had been no end-to-end testing of the security aspects of the exchange?
I think the White House was aware of the operational issues involving end-to-end testing, and I don't know the specifics of, again, I did not have the discussions about this authority to operate issue with the White House.
You testified last week in the House that it was the law that made you stand up the exchange on October 1. In fact, the statute, as I read it, requires enrollment to start. It does not require the exchange to stand up. Were you given different legal advice within HHS?
Senator, what the law says is that benefits started on January 1st. The law also said that the Secretary shall designate by regulation a date of open enrollment, and that regulation needed to be promulgated by, I think it was June of 2013.
Correct, but that did not require you to stand up the website. It required you to open enrollment.
Well, open enrollment, yes. And a significant portion of open enrollment was the website.
If Administrator Tavener had not done the authority to operate, if she had not signed it, the exchange wouldn't have stood up on October 1, would it?
That's correct. But a short-term temporary authority to operate was done specifically because she had advice from her senior IT and operations team, as well as the contractors. So
it wasn't the statute that made the website stand up on October 1, was it?
Open enrollment began, and a significant part of open enrollment was the website. Okay.
Administrator Tavener testified yesterday that the estimated target enrollment number for the end of November was approximately 800,000. And I know that your plans are to release next week that update through last month. When you release that, do we have your assurance that you'll break that down so that you'll show whether individuals chose Medicare or private plans, bronze, silver, platinum levels, and a state-by-state breakdown?
I can tell you, Senator, that we'll be able to delineate between my understanding, because that's what they're still trying to determine, is how many metrics we can give. We certainly will have a state breakdown. We certainly will have a differentiation between private coverage and Medicaid coverage. We intend to give you as much information as we can validate. I don't know that we can delineate the level of the plan.
And what is the October through the end of December target enrollment?
Senator, there are all kinds of different target enrollments that I think there was a memo internally that called for about 1 million people to be enrolled through December, but we're updating those targets. I can tell you our early enrollment numbers are going to be very low.
Okay. In an effort to set the record straight, Mr. Chairman, the Secretary's highlighted, as have others, that premiums seem to be lower than CBO projected. When CBO made their projections on premiums, CBO made some assumptions because healthcare cost is directly linked to GDP growth. And the assumptions that CBO made was that we would have GDP growth in 2011 of 3.5, in 2012 and 2013 of 4.7. The reality is that GDP growth was 1.8 in 2011, it was 2.2 in 2012, and it looks to be under 2% in 2013. So I think it's actually hugely disappointing that, in fact, premiums have now gone up so far because we've had relatively anemic growth in the United States. But there is incredible assumptions that were made for GDP growth by the CBO that went into their estimates of insurance premium cost. Madam Secretary, I thank you.
Well, Senator, I would just comment that in terms of the overall, the underlying health cost growth, the private insurance market, the public insurance plans, the first year or two after the President signed the Affordable Care Act, there was a lot of assumption that the very slow rate of cost increase was due principally to the recession. Most health economists have now concluded that there are significant cost restrainers that were part of the Affordable Care Act that actually are having a very positive impact on our health care spending, on Medicare spending, which has grown at the slowest rate in 50 years. Medicaid spending nationally went down last year overall, and private health insurance rates, again, since the Affordable Care Act were passed, have been at the slowest cost increase that has been seen in decades. So there is now a conclusion that some of the provisions written into the bill about delivery system changes, payment changes, different ways to measure quality outcomes, some of the preventive care issues have lower costs.
I'm sure all of these were included in the Manhattan Institute when they completed an analysis of 49 states and found that on average premiums in the individual market increased by 41% under Obamacare. And in my state of North Carolina, the Manhattan Institute estimates that the average increase is 136% higher under the Affordable Care Act. So I thank the chair for